So this is a list of some of the geriatric syndromes in our curriculum. Today's session is on frailty and nutrition and weight. Other geriatric syndromes include delirium, dementia, dizziness, dysphagia, gait abnormalities, hearing loss, incontinence, specifically urinary incontinence, osteoporosis, pressure ulcers, visual disorders, and hearing loss. So what is frailty? What's the definition of frailty? The word frailty comes from Latin. It has a Latin origin. It comes from the word fragilis, which means fragile. The English version is fragile. If we were to look it up in the dictionary, it would say the condition of being weak and or delicate. But many older adults may be weak or quote unquote delicate. But weak and or delicate does not satisfy the clinical definition of frailty. So what is frailty? Frailty is a clinically recognizable state of increased vulnerability resulting from aging-associated decline in reserve and aging-associated decline in function across multiple physiologic systems in such a way that the body's ability to cope with everyday or acute stressors is compromised. So what does that mean? Frailty is a chronic progressive condition. It's characterized by a gradual cumulative decline in physiologic function. It is characterized by a decrease in the body's ability to compensate or to recover from stressors, or a decrease in the body's physiologic reserve such that the body is unable to compensate or unable to recover from stressors. It's also characterized by a decrease in tolerance to acute illnesses and decrease in tolerance to extremes of temperatures, decrease in tolerance to trauma and medical and or surgical intervention. Frailty is also characterized by an increase in vulnerability to adverse health outcomes. And this includes adverse health outcomes such as the risk of falls, the risk of injury, abrasions, lacerations, fractures, the risk of disability, dependency, increased risk of institutionalization, complications from procedures, and increased risk of death. There are two concepts of frailty, two types of frailty. There's what's termed physical frailty, and there's also index frailty. Physical frailty is also called phenotypic frailty or syndromic frailty. In physical frailty, it is believed to be based on the clinical presentation. So what signs and or symptoms is the patient presenting with? The exact cause of physical frailty is unknown, but it's believed to be related to dysregulation of metabolic processes, those metabolic processes that are related to energy production and energy expenditure. Index frailty, the second type of frailty, is also called deficit accumulation frailty. And it is based on the compounded effects or the cumulative effect or the additive effects of multiple underlying conditions, multiple underlying illnesses, in such a way that the more underlying conditions an individual has, or the more underlying conditions an older adult has, the greater the likelihood of developing index frailty. Again, the exact cause is unknown, but it is believed to be associated with the presence of multiple underlying medical problems. And this is important because there's evidence to suggest that specific underlying medical conditions such as heart failure, such as COPD and emphysema, such as certain forms of cancer, and even HIV disease, independently places the patient at an increased risk for developing frailty. So how do we diagnose frailty? What's the criteria for frailty? The Fried Frailty Tool, the Fried Frailty Assessment Tool, is one of the main assessment tools used in diagnosing frailty. It's been validated by the Cardiovascular Health Study. Okay, and one advantage of this study is that it requires the participation of the patient. So the criteria to define frailty, basically any 3 of 5 characteristics would clinch the diagnosis. The first is weakness. Weakness as defined by decrease in hand grip strength. Weakness as defined by a decrease in skeletal muscle mass or sarcopenia, which tends to result in a decrease in strength. The second criteria is slowness, decreased motor performance. Third, decreased physical ability or physical activity. Fourth is self-report of exhaustion or decreased exercise tolerance. And 5% of weight loss over a 6 months to 1 year period. Okay, 5% or more of body mass decline. So any 3 of the previous 5 characteristics would clinch the diagnosis of frailty. So how would we manage frailty? First and foremost, it's important under the 4 M's framework to consider what matters to the patient, and therefore goals of care should be established with the patient and the patient's caregivers, the patient's family. Second, we ought to incorporate a multidisciplinary team-based approach. Okay, and the team would consist of everyone across the healthcare spectrum. This includes the primary care doctor, physical therapist, the psychiatrist, nurses, nurse practitioner, social worker, and again, the importance of the family and caregivers should not be overlooked. How do we manage frailty? Treat any underlying causes, any precipitating causes, any underlying medical problems. 4, minimize the number of prescribed medications. Take into account drug-drug interactions and the consequences of polypharmacy. So discontinue non-essential medications and perform periodic medication review in order to reduce the potential for drug-drug interactions and adverse health outcomes. 5, reduce or eliminate any kind of environmental risk or risk factors. Eliminate environmental stressors. 6, implement a fall prevention and a social support program. One of the main causes of frailty is undernutrition. Undernutrition can be addressed by providing access to food, providing adequate nutrition. Poor intake is often an indication of illness. Lack of access to food contributes to undernutrition, which in turn leads to unintended weight loss. Unintended weight loss, micronutrients deficiency, and vitamin deficiencies. Protein calorie supplementation is known, it's proven to delay the progression of frailty and even reverse frailty. So provide proper nutrition, including protein calorie supplementation. Vitamin D supplementation can be beneficial. Vitamin D supplementation, especially in situations where the vitamin D level is low, the serum vitamin B12 is low. Low vitamin D level is associated with a higher prevalence of frailty at baseline. Therefore, vitamin D should be supplemented. Vitamin D supplementation may reduce the risk of falls, it may preserve muscle strength and improve balance. In terms of management of frailty, it is beneficial to implement a comprehensive exercise program that can be safely tolerated by the patient. What type of exercise? Muscle strengthening exercises, balance improvement exercises, balance training, and exercises that would improve exercise tolerance or stamina. There may be a role for, in situations where patients are unable to perform exercises independently, there may be a role for supervised exercise, physical therapy, and occupational therapy. So what are some of the benefits of exercise? The benefits of exercise include an improvement in bone mineral density, improvement in balance, improvement in strength, improvement in flexibility, and improvement in mobility, which in turn translate into improvement in functional status and an improvement in the individual's ability to perform activities of daily living. Additional benefits of exercise include a decreased risk of falls and an increased sense of well-being.